Yes.
Dr. Napier, I'm going to ask you to look at the 1977 memorandum on the selection, medical examination and care of blood donors. Chairman, it's PRSE 304358, please. So if we just look at the title, we can see it's the NBTS Memorandum on the Selection, Medical Examination and Care of Blood Donors. And there's a date on page 7. We don't need to go to it, Shomik, but the date is December 1977. As far as you can recall, Dr. Napier, was this the main document to which the centres worked in terms of donor selection policy?
This document was in essence the rule book for operations throughout the centre. So we'd have done our best to comply with all those criteria.
And we know it was amended from time to time, so this happens to be the version as at the end of 1977. We can see paragraph 1 says donors should be healthy persons of either sex over 18 years of age and under 65. Paragraph 2 tells us intervals between donations, the policy of the service to maintain donor panels at a size which will permit an interval of 6 months. And then 3, the decision whether a person is fit to give blood rests finally with the doctor who is to collect the blood. And then if we can go further down the page to the bottom part, we've got a heading, section 2, medical examination of donors, and a heading, medical history. A donor is the best judge of whether he is in normal health, and truthful answers to simple questions concerning his medical history and general health form a main part of the examination. In practice, the donor session clerk should specifically question the donor about the conditions listed on form NBTS 110A and request the donor's signature on form NBTS 110. We'll look at those forms in a few minutes. In practice, a simple method of recording any declared conditions is to note them in the medical history box on NBTS 101, which should be initialled or signed by the donor or by the clerk if the donor's signature is not for some reason obtained. So would it be right to understand that the starting point in terms of donor screening, donor selection, would be asking some basic questions about medical history by reference to the forms that we'll shortly look at?
Yes, it is. The donor will have had some literature to look at, and so they could understand the important criteria which would determine their eligibility to donate. And then the donor session clerk would make a judgment as to whether the donor had understood that and request them to sign that they had read and understood and complied with the conditions stated.
And what kind of training would the donor session clerk have?
Well, they would have, I can't recall in detail, but they would have taken through the details of the health conditions that had a bearing on fitness to donate.
Okay. And if we go over the page, we can see at the top of the page it refers to 3 categories of illness or conditions. 1, those which disqualify a person from acting as a donor, e.g. cancer. 2, those which require referring to the medical officer for decision as to acceptance, deferral or rejection. And then 3, those which necessitate temporary deferment, e.g. pregnancy, contact with infectious disease, inoculations. Persons in the 1st and 3rd category should, if they ask, be referred to the medical officer. So would it be right to understand that in relation to the categories identified as 1 and 3, that ordinarily would be something that the donor session clerk could deal with without referral to a medical officer? And then category 2, the donor session clerk was expected to involve the medical officer?
I think the medical officer could be involved in any of those situations. I mean, for example, cancer, questions might arise if somebody had had cancer successfully treated some years ago. That might be a rather more complicated issue to resolve. And inoculations, the question is how long after the inoculation it might be safe to donate blood donation, how long after recovery. So I think not all these questions are entirely black or white ones, and I think the donor receptionist will, for those circumstances in which there's a lack of clarity, they will get advice from the medical officer.
And then if we look at further down the page, it says conditions which necessitate temporary deferment are as follows. The first category is inoculations. If we go further down the page, if we go to the last but one entry, Little Roman 5, if transfused with blood or plasma within the last 6 months, or if volunteer has undergone tattooing, acupuncture or ear piercing in the last 6 months, and then there should then be an interval of 6 months before the donor is bled. What was the rationale for an exclusion for 6 months of a person who'd been transfused with blood or plasma?
I think at this time, the concern would have been that these are potential opportunities for possibly hepatitis B transmission, and by 6 months it would become apparent whether infection had taken place or not, and if they were negative at this donor attendance, then that probably means they hadn't picked up any infection and they would be eligible to donate.
Okay. And then
so I think the 6 month interval is basically saying there's enough time here for any unsuspected infection to declare itself.
And then if we go to the next page and look at the bottom of the page, we can see the heading Jaundice or Hepatitis. So this was the guidance as of December 77. Individuals who give a history of jaundice or hepatitis, or in whose blood anti-HBsAg is present, may be accepted as donors, providing that they've not suffered from jaundice or hepatitis in the previous 12 months, have not been in-house contact with hepatitis or received a transfusion of blood or blood products in the previous 6 months, and providing their blood gives a negative reaction for the presence of hepatitis B surface antigen when tested by a sensitive method, RPH or RIA. An accepted test for hepatitis B surface antigen shall be performed each time a donor is bled. Donors whose blood reacts positively shall be excluded permanently from the donor panel. So I think it's right to understand from this that whilst previously a history of jaundice or hepatitis might be grounds for permanent exclusion, by December 1977, the decision had been taken to exclude individuals only if they'd suffered jaundice or hepatitis in the previous 12 months.
Yes, I think it became understood that the majority of the patients who gave a history of jaundice, it wasn't likely to be a transmissible hepatitis B, most likely hepatitis A or some other medical condition which could give rise to jaundice, but nothing that would be relevant in the context of transfusion.
Okay, I want to come back to that issue in a few minutes after we've looked at some other documents, but if we just continue with this document for now, if we go over the page, there's a heading examination of the donor. I don't need to ask you about the first paragraph, which deals with haemoglobin estimation. Paragraph 2A says the medical history, so that's what we've just discussed by reference to the various conditions and the forms. The medical history should be coupled with a careful assessment of the donor's appearance. The experienced doctor can detect at a glance the potentially unsuitable donor. Those of poor physique or who are underweight, the debilitated, the undernourished, the mentally unstable, and those bearing the obvious stigmata of disease should not be bled. Now, that might suggest that every donor should be seen by an experienced doctor. Was that how it worked in practice, or would it be the donor session clerk might refer someone to the doctor for an assessment of appearance if they were concerned about any aspect of the donor's appearance?
Well, they certainly would do so. I think those listed conditions, I think we understand that many people would be able to make the judgment about whether a particular person fell into one of those categories. But certainly if the if the receiving clerical officer was in any doubt, they'd seek the advice of the medical officer or the state registered nurse if a nurse was managing the session.
And then if we go towards the bottom of the page, there's note. It says a complete medical examination to include X-ray examination, electrocardiogram, haematological examination, etc. is obviously impracticable. The above procedure, however, if skillfully used, will lead to the rejection or deferment of donors unfit to be bled, and it should be carried out meticulously. When in doubt, it is better to reject or defer, and the medical officer should then see that an appropriate entry is made upon the donor's record card. In general, only persons in normal health with a good medical history should be accepted as donors. Is that the guiding principle, that last paragraph that we see underlined?
Yes, it is, and I think it obviously is impractical to conduct any form of medical examination in the sort of public setting of a donor session. And the principle really is, in any doubt, then to defer the donor.
If we just look at the two forms that were referred to earlier, Shomik, can we go to DHSC 0003734_066? And can we go to page 11? Should be. Yes, so if we look at the top right-hand corner, we can see NBTS 110A, revised 1977. So this looks like it tallies in terms of time and the name of the form with what we saw referred to in the memorandum. And then we can see it says, to blood donors, if you've recently been in contact with a case of infectious disease or had any inoculations or vaccinations, please tell the clerk. If you suffered from any of the following illnesses, you are not eligible to become a donor, and then there's a list of conditions. If you have had any of the following conditions, please declare this, and a decision will be made in your individual case by the doctor. And then there's a list of conditions. Halfway down that list, we see jaundice or hepatitis in the last year or contact with a case within 6 months. So this is the form that goes to the donor, and the donor looks at in the actual donor session, as I understand it. Would you agree a donor would understand from this that they only have to declare jaundice or hepatitis if it's in the last year, or if, in terms of their own health, or contact with a case within the last 6 months if it's contact with a third party?
Yes, that seems to be the case, yes. This dates from 1977. I can't recall any more detail about it than that.
So someone who had jaundice or hepatitis, say 2 years previously, wouldn't be expected to declare that to the donor session clerk?
Well, they would probably mention it. In most instances, a donor would mention that just for clarification that they were still eligible to donate blood.
And then if we look at just the rest of the form, there's a question about whether they've been in Africa within the last 12 weeks. That was because of a particular Lassa fever or other serious infections. And then please state if you have any illness at present or receiving treatment or have been abroad. So that's the donor form. And then if we go to the next page, please, Shomik. This is quite faint and quite difficult to read. If we go to the top right-hand corner, we can just zoom into the very top right-hand corner. So this is the NBTS 101 form. It looks like this is a version revised in 1979. There are earlier versions from 1965 in the papers, but that obviously predates your time at the centre, Dr. Napier. And then if we look at the form, so we can see what has to be filled in. There's details of the donor, their name, their address, date of birth, their occupation, and so on. And then there's a box, medical history. Donors must be asked whether they have ever suffered from the following conditions, and then there's a list of conditions which includes jaundice, but not in terms hepatitis. First of all, are you able to assist us in understanding why hepatitis, as opposed to just jaundice, is not mentioned on that form?
Well, this is a conversation with donors, and I imagine it would be understood that donors would know what the term jaundice meant, but probably wouldn't be so familiar with the term hepatitis.
Because what it might lead to is a case of someone who'd had hepatitis but not jaundice, so anapteric hepatitis, wouldn't be answering yes to the question posed by the form.
Yes, I can't answer that in any more detail. I think that if they had hepatitis, it's quite likely that they would have had jaundice, as I understand it.
Now, in relation to the acceptance of blood donors who had a history of hepatitis or jaundice from earlier than 12 months previously, I want to show you two documents about how that decision was taken in England and Wales, and then ask you about it. So if we could start with DHSC 0002181_051, please. You'll see, Dr. Napier, this is a health circular dated November 1976, so it predates your appointment at Cardiff by a few months or so. And then if we look at the bottom of the page, paragraph 4, it refers to changes recommended by the advisory group, and that's the advisory group on testing for the presence of hepatitis B surface antigen and its antibody. We looked before lunch at the third report of that group. This is a reference to the second report of the group. And we can see paragraph 4b says, the practice of permanently excluding from the panel donors with a history of jaundice may be discontinued, provided that hepatitis surface B antigen is not detected by the tests and that the donors not suffered from hepatitis or jaundice during the previous 12 months. So the recommendation of the advisory group was that donors with the history of jaundice or hepatitis could be readmitted to the panel. And then if we look at DHSC 020019_002, please. This is the Regional Transfusion Directors meeting at the 6th of July 1977. The first one which you attended, we looked at it for different purposes earlier. If we go to page 3, and we look at the top part of the page, it says this, picking it up in the second line, the members agreed that the following paragraph should be inserted into previous leaflets in light of the recommendations of the Working Party on Hepatitis. In conformity with expert evidence and advice, the National Blood Transfusion Service has decided that volunteers with a history of hepatitis, brackets jaundice, may now be accepted as blood donors, provided that they have not been in house contact with hepatitis or received a transfusion of blood or blood products in the previous 6 months, have not themselves suffered from the disease in the previous 12 months, and are shown to be hepatitis B antigen negative by a suitable laboratory test at the time of the donation. So we can see from that, Dr. Napier, how the decision was taken to allow volunteers with a history of hepatitis to donate blood. Conscious that this was your very first meeting as a regional transfusion, in fact, I think you weren't even at this stage the regional transfusion director, you were there in place of Dr. Bevan. But do you recall, either then or in any subsequent years, any discussion about whether this was the right course to take to admit donors with a history of hepatitis?
Well, these decisions weren't taken within the expertise of the transfusion service. We were taking advice from a group of expert virologists who had a better understanding of the infectivity of donors in these various circumstances. So we took their advice in terms of formulating our guidance.
Want to look then at a piece of international advice from around the same time, which is DHSC 0002179_067. This is the 1976 publication of the International Society of Blood Transfusion. We looked at its second chapter this morning, Dr. Napier. This is its first chapter on the criteria for the selection of blood donors. If we pick it up at page, sorry, in fact, I should just say, if we go to page 2, we can just see a little more about the International Society of Blood Transfusion, and we'll see that its executive council included Dr. Tovey, who was a past president of the society. If we go to page 7, so this is dealing with the issue of donor selection. If we take it, the top paragraph, first of all, by way of background, says the non-remunerated blood donor is the essential element around which every blood transfusion service is shaped. None should join this select group whose blood may transmit disease to his fellows or whose health may suffer as a result of his generosity. So that's the guiding principle. We've then got a heading, examination of the donor. I'm not going to ask you to go through that. If we go over the page, we've got a sample donor selection form with a range of different questions. And you'll see question 5 is, have you ever had hepatitis, brackets, yellow jaundice? And then if we go to the next page, there's another sample form. And again, we see the question, have you ever suffered from? And the first item there is jaundice. And then if we go to page 12, there's a heading, viral hepatitis. In spite of recently developed tests for the detection of hepatitis B surface antigen, only a relatively small proportion of carriers can presently be detected. No routine screening test is presently available for the detection of hepatitis A virus or of other viral agents that cause transfusion-associated hepatitis. It follows, therefore, that some general precautions should be taken in an attempt to reduce the risk of such viral agents being transmitted from donor to recipient. Prospective donors should be excluded if it is known that they, 1, give a history of viral hepatitis at any time, except during the first months of life. And then in brackets, this rule may not be acceptable in all countries and may have to be modified where viral hepatitis is endemic. And then it continues in relation to those who've received a transfusion or been in close household contact. So the guidance of the International Society of Blood Transfusion was to exclude donors with a history of viral hepatitis at any time. It may be that you can't help us with this, Dr. Napier, in light of your answer a moment ago, but do you know whether any consideration was given by the regional transfusion directors to this guidance or to the different approach that was being outlined here?
Well, I can't answer that question, but this is an evolving position, and within the UK, the expert advisory groups would have been fully cognizant of the International Society of Blood Transfusion guidance, which, and as I said, I think this is 1976. We've been looking at UK guidelines in 1977. The methodology for hepatitis surface antigen testing had improved to a great extent, a large amount in this period of time, insofar as the tests were much more reliable about excluding donors who could transmit hepatitis. So I think we take our guidance from our own UK expert advisory group, who would also consider opinion shared internationally. I can't say more than that at the time. These are complex questions, and I am quite certain that each of the points that you brought up have been debated in considerable detail, and our guidance follows the advice from the expert advisory group.
Would you accept that changing practice so as to admit to the donor panel donors with a history of viral hepatitis from 12 months or longer ago might increase the risk of transmission of non-A, non-B hepatitis, for which there was, of course, no screening test?
I'm afraid you have to ask an expert virologist. I don't have the knowledge to answer that question. All I can say is that these matters were deliberated in detail by people expert in hepatitis.
So in terms of the way in which the decisions would have been taken, is it right to understand your evidence as understanding that the regional transfusion directors and the National Blood Transfusion Service would essentially have taken its lead from what was being recommended by the advisory group, rather than necessarily reaching its own independent decision on the issue?
It would have taken advice from the advisory group, which was accepted by the Transfusion Service. I can't see any likelihood that individual directors or transfusion services would have taken a less safe approach than that.
If we move on from 1977 to 1983 on this issue, and we look at NHBT 001 0654 underscore 004, yep, NHBT 001 0651 underscore 004. Dr. Napier, this is a recommendation R838 of the Committee of Ministers of the Council of Europe in June 1983. If we go to the second page, you'll see from the top of the page, these are recommendations being made in the context of AIDS. And one of the recommendations, and this is paragraph 1, and it's the third bullet point, was to provide all blood donors with information on AIDS so that those in risk groups will refrain from donating. An example of an information sheet for donors is appended. Now, I'll come on to ask you at a later stage of your evidence about the AIDS leaflet. But if we then look further down the page, this is the sample or example of an information leaflet that was appended to the recommendation. This page deals with the issue of AIDS. Again, we'll look at that later. If we go to the next page, top of the next page, you'll see hepatitis. Persons with a past history of viral hepatitis are deferred permanently. So it would appear to have been the view of the Committee of Ministers of the Council of Europe in 1983 that the right course to take was permanent deferral of those with a history of viral hepatitis. Do you recall whether this recommendation was ever considered in or after 1983 by the regional transfusion directors?
I can't suffice it to say that we took our advice from UK experts on hepatitis and virology. I can't say more than that. I wouldn't have my personal expertise to make a comment on this.
If this particular issue had been discussed by the regional transfusion directors, would it be realistic to assume that discussion would be minuted in one of the sets of meetings, of the regular meetings of the regional transfusion directors?
I would imagine so, but I've no recollection of that, I'm afraid.
If we then just look at NHBT 53225, please, Shomik. So this is the now entitled Guidance rather than Memorandum for the Selection, Medical Examination and Care of Blood Donors. Dr Napier, I don't know the precise date of this updated guidance, but it's clearly either, from its content, it's either 1983 or after 1983, because there's reference to 1983 in the text of it. If we just go to the second page, we've there got the heading Medical Examination of Donors, and we see again, in similar terms to the 1977 text, the second paragraph refers to the donor session clerk questioning the donor about the conditions. And then we have a list of conditions. We can see the reference there to AIDS. So by this time, the decision's been taken, AIDS amounts to disqualification from being a donor. We go to the next page. We can see the third entry is drug abuse. That again leads to disqualification. And then further down the page, we can see there the heading hepatitis, and the suggested action is refer to MO. That would be the medical officer, presumably.
It would.
And then top of the next page is jaundice, refer to MO. And then if we go to the next page, page 5, we've got notes on some of the above who require deferment. And if we go just over halfway down the page, we've got little Roman 4, history of hepatitis, jaundice, 12 months, but see Appendix 1 under hepatitis. And then if we go to page 11, just to complete the picture, this is the section on hepatitis in Appendix 1. It's in similar terms to 1977. Individuals who give a history of jaundice or hepatitis or in whose blood anti-HBS is present may be accepted as donors, providing they've not suffered from jaundice or hepatitis in the previous 12 months, have not been in close contact with hepatitis or received a transfusion of blood or blood products in the previous 6 months, and providing their blood gives a negative reaction for the presence of HBsAg when tested by an accepted sensitive method, e.g. RIA. So the position in or after 1983, whatever the precise date of this document, is the same as 1977. In relation to hepatitis, a history of hepatitis doesn't exclude donors from giving blood unless it's in the last 12 months. Do you recall whether that position ever changed, Dr Napier, up until the autumn of 1991 when we get to the introduction of hepatitis C screening?
I'm afraid I can't throw any more light on it than that. All I can repeat is that our practices were based on the advice we were given by expert committees.
Now, I've been asking you about the assessment or screening of individual donors. I just want to ask you now about a couple of groups of donors. The first is military donors. We've seen from, so we can take the document down, Shamik. We've seen from one of the earlier South Glamorgan Health Authority annual reports that we looked at in the tables that Cardiff probably collected from blood from members of the armed services. Do you recall whether the centre collected blood from, for example, US servicemen?
I'm not sure. I think it's unlikely, but I can't categorically say one way or the other.
Okay. And do you recall any particular military establishments from whom the centre collected blood in the late 70s or in the 80s?
I think it's likely that we had donation sessions at the RAF Centre at St Athens near Cardiff, but again, without looking at contemporary documentation, I can't be sure about that.
I want to ask you next then about another group of potential donors, and that's prison donors. If we start by looking at a letter from 1975 from the Chief Medical Officer, just to set the background, it's PRSE 609. Dr. Napier, this is a letter of the 1st of May 1975 from Sir Henry Yellowlees, the then Chief Medical Officer, to all regional medical officers on the topic of blood donation and hepatitis. Now, this is obviously before you took up your role in Cardiff. Maybe impossible for you to answer this, Dr. Napier, but do you recall if you ever saw this document at the time?
I'm sorry, I don't.
If we go to the second page in any event, there's a heading prisons. Says there is a relatively high risk of hepatitis B being transmitted by the blood of prisoners, but there is probably an equally high risk in other groups of the population, e.g. drug addicts, who are not so easily identified in advance as prisoners if they can be identified at all. The advice we have received is that it's not necessary to discontinue the collection of blood at prisons and similar institutions, provided all donations are subjected to one of the more sensitive tests referred to above. And then there's a reference to an intention to revise the memorandum that we looked at a few minutes ago. As I understand the position in relation to the Cardiff Centre, you continued collecting blood from prisons well into the 1980s. Is that right?
Yes, I can't recall the exact date in which we discontinued. It was in the early 1980s, and this coincided with the practice of stopping prisoner donations in all the regions of the UK, and that includes Scotland. I think we all decided to discontinue prison donations around the same time. Prior to that time, it had been understood that encouraging prisoners to donate was helpful to them. It was, in a way, part of the rehabilitation in society, and it was a valuable practice to undertake. And only later did it become clear that the prison population did have a higher a proportion of people with positive hepatitis B markers. Of course, having said that, the prison donors also had to consider the donor selection advice that other donors had, which would be advice about drug use, about hepatitis and general health matters. So there was that screening before donation. But so the figures that we have for the higher incidence of hepatitis B markers in the prison population, I don't know what the incidence of hepatitis B markers is amongst prison donors. I've not seen figures for that, and that would be obviously an important consideration. But once it was generally understood that there was a significant increase in hepatitis markers in prison donors, it was decided to discontinue their donation.
We can take that document down.
No, I just leave it up for a moment. I just want to ask you if you can help me with the second sentence. The argument that Sir Henry Yellowlees is putting forward in this is that it is not necessary to defer prison donations. What part do you see logically the second sentence as playing in that at all? He seems to be saying that there is a high risk of hepatitis B from prison donations. Part of the reasoning, perhaps, in the next sentence, otherwise it's got no purpose of being there at all, is to say, but there's another group which has also got a high risk. If you have two separate groups, each of which is high risk, why does the existence of one allow you to go on taking donations from the other? It doesn't make sense, does it?
I agree, but I just repeating that there was the selection stage in which donors are asked to consider their eligibility to donate. Did they have a history of hepatitis or drug use and such like? And I think it was probably assumed that that self-deferral or exclusion at the donation session, coupled with the increasingly sensitive hepatitis B screening, would be sufficient to enable them to continue as donors. But obviously that policy changed within a few years. I can't say more than that.
We can take that down, thank you, Seamus. We saw from the memorandum on the selection, etc., of donors, that there was an expectation that the donor would be the best judge of their fitness and would be expected to give truthful answers to questions about their medical history and health. Do you recall either yourself giving consideration or being aware of consideration being given by others to the possibility that prisoners may be in a situation in which giving truthful answers about activities such as intravenous drug use could be quite problematic?
Well, I think you're right in supposing that could be the case. I think that the doctors responsible for the actual collection of blood can see evidence of intravenous drug abuse. It leaves marks on the skin, and so I think there are other signals that the person collecting the blood can recognise that might lead them to suggest that this donor is not suitable. I can't be more precise than that, but I think experienced medical officers or later on nursing staff can get cues that suggest that a given donor may not be as suitable as might otherwise seem.
If we look at NHBT 011 3565, these are the minutes of a meeting in Cardiff on the 7th of December 1984, and it's the Western Division of Consultants, and we can see that you were present. We go to the second page. Under the heading Further Matters, Prison Sessions, it says Birmingham, Bristol, Oxford and Southampton have all stopped carrying out blood collection in prisons. Cardiff would probably stop in the near future. Now, that would suggest that as at December 1984, Cardiff was still collecting blood from prisons, which might be thought to be quite late in the day in terms of what was by then known about AIDS. Are you able to assist us in understanding why the practice of collecting blood in prisons didn't stop earlier in Cardiff?
Without seeing the information about what sessions were planned and taking place, I can't answer that question. I think it's unlikely that Cardiff would have purposefully considered collection sessions in prisons any later than anybody else, but I can't answer that in more detail now.
I think we're likely to hear evidence later this week, Dr. Napier, that, for example, the North London Regional Transfusion Centre had stopped taking blood in prisons in the early 1970s. So it doesn't appear as though there was a universal practice across at least England and Wales. We'll explore the position in relation to Scotland with other witnesses. Do you, were you aware that there was at least one centre that was not collecting blood from prisons in the 70s and early 80s?
I might have been. I can't comment on that now.
I come then to the an issues about record keeping within the centre and reporting of cases of post-transfusion hepatitis. We start by looking at RLIT 40215, please show me. Now, this is a document from 1953, I think, the Expert Committee on Hepatitis of the World Health Organization.
I think that's when it was printed. It was actually a report in 52.
You're right, sir. Yes, it is. If we go to the next page, to page 2, yes, Expert Committee on Hepatitis, and there's reference to the sessions taking place in July 1952. And then if we look at the bottom of that page, it refers to a report being issued in August of 1952. Thank you, sir. If we go to page 17, there's a section there headed "The Prevention of Spread of Hepatitis Viruses A and B by Human Blood and its Products." The committee is of the opinion that the dangers of serum hepatitis are not appreciated by many sections of the medical profession, largely owing to the long incubation period which conceals the relationship between a transfusion and subsequent hepatitis. It also appears to the committee that many non-essential transfusions of blood and plasma are given. Therefore, the committee recommends that national health authorities should call the attention of the medical profession in their countries to the dangers of transmitting hepatitis by transfusion of plasma and whole blood, and also by the use of certain blood derivatives, and should advise that plasma, particularly large pool plasma, should not be used unless the advantages likely to be gained by its transfusion outweigh the risk of transmitting the disease. So that's the preface to this section of the report. If we go over the page, Dr. Napier, you'll see below the table there's a heading 10.2 preventive measures, and then there are 4 measures identified by the World Health Organization. The first is about the screening and selection of blood donors, and I've already explored that with you, so I'm not going to ask you about that again. If we go to the next page, paragraph 10.2.2, so the second preventive measure identified is about the size of plasma pools. Again, I'm not going to ask you about that because that's something in terms of fractionation beyond your control. If we go to the next page, we've then got 2 headings, maintenance of records and reporting, and I just want to look at those and then ask you about the practices at the Cardiff Centre. So subsidiary but important means of control are afforded by the maintenance of accurate records of the origin, distribution and administration of blood and blood products. Such records should include 1, record of the names, etc., of donors contributing to each product. 2, recording of batch numbers of products issued to hospitals and systematic distribution of products to hospitals. 3, accurate recording in the patient's case papers of the batch number of the product used, with the date of administration and of the patient's name in the hospital record of products received and issued. In view of the importance the committee attributes to this matter, it's recommended that 1 individual in each hospital should be made responsible for ensuring the proper completion of these records. Now, first of all, Dr. Napier, would you agree with what's set out here, that these are important requirements in terms of the maintenance of records?
Yes, certainly. Of course, your points 1 and 2 are the responsibility of the transfusion service. And my understanding is that these were taken very seriously, and especially when the services implemented computer systems, the records for all of these were maintained to a very high standard. As far as point number 3 is concerning, that's a responsibility that can only be undertaken in each individual hospital, and I think this was discharged with various degrees of efficiency. I can't. I know that certainly there are difficulties in implementing this system of having an accurate record in patients' case notes and in locating patients' case notes some years after transfusion are given. So it's a substantial responsibility, but it's one that's held within the hospitals rather than the transfusion service.
Yes, Dr. Napier, you're absolutely right. So, and 1 and 2, as far as you're concerned, would have been part of what your centre did in terms of its own record keeping. You would expect names, etc., of donors and details of what was being issued to hospitals those records to be faithfully recorded within your centre.
That's the case.
And then 3, as you say, relies upon the hospital doing its record-keeping work. I'll come back to that if I may in a moment. If we could then just look at HCDO 40861. This is headed Notes on Transfusion, revised 1973. It's the precursor to the handbook that we looked at from the 1980s earlier this morning. So this obviously predates your appointment, but would it be right to assume that this is a document that you would have been familiar with?
It is.
And then if we go to page 18... this is headed Transfusion Records, and this is essentially concerned with the category 3 that we looked at in the World Health Organization report, so the records that should be maintained in the hospital. A record of every transfusion should be made in the patient's case notes, in addition to the details recorded in the transfusion laboratory. It is not always appreciated that the main reason for accurate recording is the protection of the patient. The patient's records must show, and then there are 4 requirements set out. 1 is serial numbers of containers of blood or blood products. The recording of these numbers must never be omitted, since they may be the only means of tracing and checking a donor's blood if there's any question of incompatible transfusion or serum hepatitis. In the latter instance, it's important not only to be able to trace the donor bearing the infective agent, but also to be able to trace and withdraw other containers of the same icterogenic batches. Only by the careful and invariable recording of serial numbers of containers of transfusion fluid can this be accomplished. In all cases of suspected post-transfusion serum hepatitis, tests of the recipient's serum for Australia hepatitis-associated antigen should be performed. This can normally be done by the Public Health Laboratory Service. And then this, the regional transfusion director must also be informed immediately so that further tests can be made of the blood of the donors concerned. And then there are a number of other matters which are required to be set out at Little Roman 2 through to 5. I'm not going to ask you about that. And then 2 is laboratory records. So the first was the patient's records, second, laboratory records. The responsibility of the pathologist in charge of the hospital transfusion laboratory. Such records should show the following details of the use of all blood and blood products. The blood bank register should show 1, date and time of removal of the blood from the blood bank, 2, name of person fetching the blood from the blood bank, 3, full name, ward and hospital number or home address of recipient, 4, blood group of recipient, 5, serial number and blood group and date of collection of each container of blood transfused. Top of the next page. Clinical condition necessitating transfusion, reactions, if any, stating their nature, whether the patient has a history of various things they're set out, name of doctor giving the transfusion, and then it says the plasma or plasma protein fraction register should show similar information, and then 3, the doctor in charge of the above records should at regular and frequent intervals satisfy himself that unused units of blood or blood products issued to the wards and theatre have been returned to the hospital blood bank. So it's right to understand, I think, from this, Dr. Napier, that in terms of the records kept at the hospital, there were 2 categories of records, the patient records and the laboratory records. And this document was intended to emphasise the absolute importance of those records being completely filled out and maintained. Sorry, would that be right?
Yes, that's certainly the case. The hospital transfusion laboratory do have a significant challenge because the request form for blood may well not have all the information they want. It's quite unlikely to have all the information which is listed on, you've just shown me, the previous history. I mean, many transfusions are requested as a matter of extreme urgency and sometimes rather scant clinical information justifying the transfusion, but the laboratory has an obligation to prepare the blood and make it available so that the patient's health isn't in jeopardy. So it's not always possible to comply with all this information, despite many people understanding its desirability. But the hospital transfusion laboratories are obviously very often high pressurized, busy situations, and patients sometimes change their ward, and sometimes the information just isn't as complete as the laboratory might wish. But I think they make a good attempt to make a record of the information that they've been given in terms of allowing tracing of the destination of any blood and blood products.
And did you, as the regional transfusion director or the regional transfusion centre, have any role in checking the extent to which the hospitals to whom you were supplying blood or blood products were complying with their record-keeping requirements?
We didn't have any jurisdiction in this matter. We did obviously have professional contacts in which we would agree the desirability that all this should be done. And I think most professional colleagues did their very best to ensure compliance. But as I've mentioned, there are difficulties in a busy hospital blood bank. They don't always get the information they need to justify the need for transfusion. Sometimes they're urgent situations, but by and large, I think the hospitals, the transfusion laboratories, made good efforts to record the destination and types of material that are supplied to patients.
If we just move forward in time to the 1980s and look at CBLA 0001819, this is a circular issued by the Department of Health and Social Security in March of 1984, and it's headed Blood Transfusion Record Keeping and Stock Control Arrangements. We go to the second page in the heading Record Keeping. It says this at paragraph 7, for medical reasons and from the point of view of accountability for a valuable resource, records kept at RTCs, hospital blood banks and at ward level must permit the tracing of any unit of blood from collection to transfusion or disposal. Health authorities are asked to ensure that the systems employed at transfusion centres and hospital blood banks do so. And then paragraph 8, to enable hospital blood banks to account readily for blood and blood products received from RTCs, consultants responsible for blood banks are asked to make a monthly statistical return to their RTC listing, and then we can see a number of matters there set out: number of units of blood and components received, number held in stock, number returned, number used, and then at F, a note of the fate of all other units identified by unique number. And then paragraph 9, systems must be flexible enough to meet local needs, priorities and circumstances, while at the same time embodying the essential principles of accountability and patient safety, which are 1, to account for all blood received, issued and used at RTCs and hospital blood banks, including blood returned to RTCs, 2, to enable each unit of blood to be traced from donation to disposal, and 3, to provide data on which to base decisions about optimum stock levels. Now, as far as you can recall, did you, after the date of this circular, receive monthly statistical returns from the consultants responsible for blood banks covering these issues?
I know we received returns from hospitals giving us, as far as I can tell, most of this information. What frequency we receive the returns, I just can't say at this time, but I think at least on an annual basis we'd have had, as far as I understand, we'd have had most of this information.
If we go back to the World Health Organization report at RLIT 40215, page 20, we looked then at maintenance of records. I now wanted to ask you about the fourth preventive measure identified by the World Health Organization, which was reporting. The question of notification of cases of hepatitis is discussed in Section 8. However, the committee feels that useful additional information might be obtained by a simple follow-up system to detect cases of serum hepatitis following administration of blood and blood products. The institution of such a system in conjunction with the above records would make it possible to withdraw an icterogenic blood product at the earliest possible moment. The committee suggests that each patient receiving a potentially icterogenic blood product should be given a card explaining that jaundice sometimes occurs as a late complication of the treatment, and that if it should occur at any time up to 160 days after the treatment, he should visit his own doctor or the hospital. The card should carry the address of the local health authority, hospital or blood transfusion centre, as the case may be. It should be enclosed in an envelope and posted by the private doctor when the patient reports with hepatitis. Such a simple follow-up system will not detect all cases of serum hepatitis, but it is believed that in certain areas the system will detect an appreciable number of cases which would otherwise be missed. It's suggested that it should be tried on an experimental basis in selected areas in the first place and only adopted on a large scale if the results justify it. However, under special circumstances and where conditions permit, the value of the follow-up system would be greatly increased by arranging for a visit to each patient after 160 days. Such a scheme would require additional staff and would need to be carefully planned. If it is to be valuable, it's therefore recommended only as a special study in selected areas. Now, first of all, what system, as far as you can recall, was in place in relation to your centre and the hospitals you supplied in terms of the reporting of cases of post-transfusion hepatitis?
Hospitals will have notified us if a patient was discovered to have or believed to have contracted hepatitis B. This wasn't a common situation. I can't give numbers now. And that would have instituted a follow-up system on behalf of the transfusion service. We'd have retested any residual sample from that donor. We'd have followed up where other constituent parts of that donation might have been sent. We'd have followed up the recipients of any other parts of that donation, and I think we would have followed up recipients of donations given previously. I can't give details of that now because it's so long ago, but I can't speak to the hospital systems for giving patients cards and following them up. That would be out with our control and responsibility. But certainly the transfusion centre would have had a follow-up system if they were notified of any case of apparent transmission of hepatitis.
And if cases of post-transfusion hepatitis were reported to the centre by hospitals, was there then any reporting obligation on the centre to report that elsewhere, for example, to the Department of Health or to any other individual or body?
Well, I can't recall details. Certainly, as far as Cardiff was concerned, we produced an annual report, and any incidents of this nature would be in the annual reports, and that would be made available, for example, to the health authority and the chief medical officer, and I think we will also have sent it to the consultant advisor to transfusion. I can't recall details of any other notification system which may well have operated, but it's so long ago I don't have the details of what that would be now.
We can take that down, thank you. Just going to move then to a slightly different topic, which is about the use of transfusions.
Well, if you're going to do that, can I just ask one small question which arises out of the exchange you've just had with Council, and it's about records. And when you sent plasma to BPL, did you send that plasma as individual donations or as a bulk pool?
would have sent them as individual donations. I'm not sure about the very early years of the late 70s or early 80s. I think some pooling might have taken place. I really can't recall. But latterly, the packs were frozen and packaged as like a milk crate of frozen donations, and the blood products laboratory would have received those as single donations from individual donors. In the late 70s and early 80s, I'm not completely certain. Some pooling may have taken place, but I cannot recall at this stage.
And what information about the donor was sent with the pack of plasma?
There would be a donation number assigned to the pack, and that would be linked to the donor's donation record in the transfusion centre. I don't think the blood products laboratory would have had any more information than that, but if they had any concerns, all they had to do was to get the assistance of the transfusion service, and the transfusion centre would then have much more information about the donor.
Now, it may not be easy to track through what might happen if somebody who had a blood product made from that particular plasma later thought that they had got hepatitis B or hepatitis non-A, non-B from that particular bit of blood product. It may not have been easy for that donor to have ascribed their condition to any particular blood product. But if they did, presumably they would report it to the clinician, and the clinician would report it to who? The blood products laboratory? How would it ever get to you? Did it ever get to you as regional transfusion director via the blood product plasma route that perhaps somebody who'd given plasma to one of your donation centres had actually been infected, or might have been infected, with a form of hepatitis? Can you ever recall that happening?
If any patient had developed hepatitis following transfusion of blood or blood product or component, then we should have been notified, and we would then have notified the blood products laboratory if say a blood product had been involved.
But forgive me, because the person receiving the blood product wouldn't necessarily know that it was your regional transfusion centre, because there may be a number of regional transfusion centres whose individual bags of plasma had been put into a pool from which a product was made. And so my hypothesis is that there is a pool. The blood products laboratory is the body which knows, or ought to know, because it's got the information, where the plasma, which is the source of that pool, comes from. Any report might go to the blood product laboratory. If it does, one would have thought they should notify the regional directors that their donation might have been part of this pool. It might be somebody from their region who had donated. I was just really inquiring whether you ever got any information back from BPL saying, we think we've had a problem with this particular batch. Somebody's reported they had hepatitis. They think it's come from your batch. Could you check these donation numbers?
Yes, that would happen. I think the notifications of possible infections were most likely in the coagulation factors, and the haemophilia centre directors or doctors would have been involved with that. As regards the other blood products, such as albumin or immunoglobulin products, to my knowledge, the chances of transmissible infection from those is, well, extremely small, if not zero. So it would be the haemophilia centre doctors and directors who would be most alerted to the possibility that one of their patients had suffered a consequence of possibly an infected donation, and they would have records of the batch numbers of blood products that they'd been given, and would either notify us or notify the blood products laboratory accordingly. The blood products laboratory would then examine the constituent donations that might have been involved in those episodes.
And
I don't know if that answers the question.
well, it does in part. That you've described the system that might have operated. Do you ever recall it actually happening?
I think this will be handled by the Haemophilia Centre directors. I would have known about it at the time, but it would have been coagulation factor products and affecting patients that they were in care of. I think I'd have known about it, but I don't think I'd be at the most important link in the chain of information. I think they would have had the Haemophilia Centre directors would have reported that directly themselves, as well as notifying us of the episode.
Well, can I just take it a stage further? Suppose you had become aware of a report made by one route or another to you that somebody who had donated blood to a collection centre which was under your bailiwick, who would deal with it in your organisation? I don't suppose you would yourself do that. You'd be too busy. But somebody might have done it. Who would it be?
I'm sorry, the person that's donated blood, are they, I'm trying to, what is the situation?
The thesis is this, just to help. What I'm just inquiring about, because I really want to get clear in my idea what might have happened. Somebody gives blood, and the plasma from that donation is collected, and it is sent by your centre to BPL. BPL make products from it. They make various different sorts of products, and it might be that they made a coagulation factor concentrate. That gets sent out to one of the centres around the country. Probably, if it comes from, the plasma comes from Wales, it may go to Wales, but it may be part of another batch which goes somewhere else. You get to hear that somebody who has received that batch thinks that they have got an infection from receiving that batch. That they get in touch with, they talk to their doctor, their Haemophilia Centre doctor. He will talk to you, probably, or the Regional Transfusion Directors organisation. Who would actually do the checking then to see where the donor was, or what donors there have been to that particular batch?
Well, it prevents a challenge to Bioproducts Laboratory because they will have received information that suggests one of their pools is contaminated.
Yes.
So they will have a list of hundreds, if not more than that, donors. They will examine their own test results. I'm not privy to exactly what they will do in terms of testing, but they will also then correspond with the transfusion services that provided donations to that pool to re-examine their records. And what the Transfusion Centre probably will do is to see if any of those donators donated subsequently. It's conceivable that at the time the implicated donation was given, they were tested negative, but they were early incubators. So if they turn up again to donate, they'll declare themselves as positive or negative. So there'll be a trawl through of records and test results to see if it's possible to find out whether any of the donors or donations who were part of that suspected pool could be shown to be have been infectious. It's a challenge, and which would be undertaken. But sometimes it may not be possible to pinpoint the source of the infection. But that's the process that would be undertaken. The bioproducts laboratory would examine their records, and we would be asked to re-examine our own records, and which would involve examining perhaps the fate of any other. If the plasma had gone to the bioproducts laboratory, then the red cells and perhaps the platelets might have gone to local hospital recipients. So we would then be following those up as well. It becomes, with large numbers, it becomes an extremely demanding challenge. But and obviously, it's, if you've got a list of some hundreds of potential donors, it's not realistic to be able to do that. But if there's strong possibility that any given donor is suspect, then we would look at all possible opportunities to see whether that donor contributes to any other episodes of infection.
Well, thank you very much indeed. Thank you.
And so there are a couple of documents that are examples of communications between BPL and Dr. Napier or his staff. One deals with a particular infected batch infected with HTLV3, and I'll come on to that probably tomorrow. But perhaps we could just look at, as an example, CBLA 304428. It's just a snapshot. We don't have a full account. But it's a letter of the 4th of August 1986 from Dr. Trenchard, who was Dr. Napier's deputy, I think, deputy medical director, to Dr. Snape. And it records that there'd been a telephone discussion about a possible case of post-transfusion hepatitis. And then an account is given about what had happened in relation to a donation. So donor's blood obtained, transfused to a patient who developed hepatitis. Part of the donation had gone into a pool, and then an explanation is given and details of that are provided. And it's described as the donation was being put into wedge batch 3944. And then Dr. Trenchard records that he checked with the centre's own laboratory and find that they probably already notified Dr. Snape in writing of the above numbers. But then he records some further checking about the same donor and how that went into a pool. So that would appear to be an example of the kind of exchanges that might take place between the Regional Transfusion Centre and the Blood Products Laboratory. I don't know whether Dr. Napier can add anything by reference to this document.
No, I can't. I recollect seeing the correspondence. It sounds like a difficult diagnostic case because it doesn't seem as though they were ever hepatitis B surface antigen positive in our tests, but it does say anti-HBC antibody positive, which suggests that they had at some stage hepatitis B infection.
And then there's just one further document, perhaps before we break, because it's on a similar theme, although not identical. CBLA 0012682. This is an earlier letter, and this is a letter from you, Dr. Napier, to Dr. Lane, the director at BPL, 8th of December 1981. You thank him for his letter concerning hepatitis testing. And then you say, most unhappy at hearing of our missed positive result. I do feel that the incriminating sample must have escaped testing in some way, as despite the relative sensitivity levels of ELISA and RIA, there should have been no way that the original donor, with around 20 UGML, should have been nursed. And then you talk about a review of quality control procedures. And then you say this, Dr. Napier, in the next paragraph. In my view, the relevant question is not so much the testing method sensitivity, but the organisational procedures that ensure that every donation gets tested. As you know, there are various reasons why this may run the risk of not occurring. Are you able to assist us in understanding what you mean in that second paragraph there, which appears to suggest that there might be donations that are not tested for hepatitis B surface antigen?
Yes, I think it comes back to my earlier point about the justification for computerization. because under a computerized system, when the donor gives his donation, then samples are also allotted into a series of sample containers, each of which has a specific barcode label. All the labels obviously agree with each other, the donation pack and the subsamples in little test tubes. Now those then go, when they arrive at the transfusion centre, directly to the analytical apparatus, which, and they have procedures for scanning that barcode, so the computer system knows that it's read the barcode on that sample, which is linked to the donor concerned, and then the machine performs the analytical test, the hepatitis test or what have you, and that's the result is linked to that barcode, and that's becomes a secure system. Before that was developed, then you rely on individual people pipetting out the serum out of a tube into another tube and labeling it accordingly and putting these tubes into racks, all with this transcribed label. And the analysis then takes place of those samples. Now, if they made some error, and I can't conjecture what that might be, but it's a manual system, and it's just conceivable that some error or inattention might have misplaced the tube, might have been in the wrong place, or perhaps not sampled adequately. It is impossible to conjecture at this stage what might have happened, but the advantage of the soon to be developed automated system was that there should be a very secure tie-up between the point at which the donor gives the donation, labels are affixed in a secure fashion to all the constituent parts, and the equipment which samples and analyzes the sample reads the barcode and assigns the test result, positive or negative, to that barcode, and that information is then linked to the donor record. That comes close to our objective of a zero error procedure. But when you're relying on manual procedures of passing out things and labeling them, then there is a possibility of error. But once the error's taken place, it's sometimes difficult to work out what that could have been sometime afterwards. But so I'm at a loss now, and probably was at a loss then as to what could have happened. There are other, I suppose, scientific reasons why a strong positive under some test systems doesn't always respond as a strong positive. They're rather complex sort of technical and scientific explanations, but so it was a disturbing episode, and I'm not sure now at this stage I know exactly what had gone wrong. But I do know that as we and other transfusion centres, you evolve and make more secure your test procedure, and hope eliminate these sorts of mishaps.
Thank you. So probably a good moment for a break then before I move on to the next.
Yes. Well, shall we come back at shall we say 10 to 4?
Yes.
10 to 4.